So good morning, everyone. I know that that's the talk just before the break, so I'll try to make it short and sweet. We're going to go through the necrotizing otitis externa and skull-base osteomyelitis as well. What I'm hoping to get through to you is basically mainly for also our kind of more junior colleagues, how to diagnose and manage NOE and the differential radiological investigations and their limitations as well. I'll just touch base on the actual practical difficulties that we encounter in managing these patients and hopefully point you towards a possible protocol for management of these cases. So if we start first, the legs that I'm going to stand on are basically, of course, literature and mainly one study done by a French group in 2013, where they basically looked at 48 publications and they did a systematic review. Sorry, I'm just getting the laser pointer. Yeah, 48 publications spanning a period from 1972 to 2011. But also, we've done our own series where we could identify 29 patients over a period of about 3 years with the NOE and skull-base osteomyelitis. So what is it? Sorry. The NOE it's an aggressive and invasive infection that starts in the external auditory canal, but it does not stay within the soft tissue as the normal otitis externa. It actually extends to involve the bone, causing temporal bone osteomyelitis. Then it can spread along the base of the skull to cause skull-base osteomyelitis. Actually, the first published series were in 1968 by Chandler. So this problem has been around or diagnosed around for a while. And why is it important? It's actually important because it is quite an aggressive infection, and there is about 14%. There's different numbers, of course, about the disease-specific mortality, but there is mortality associated with this, and we'll find out in a second why. And also, there is a potential for significant morbidity. So these patients can develop paralysis of cranial nerves. They can get sinus thrombosis and intracranial complications in the form of meningitis, cerebral abscess as well. So who is the actual target patients for this nasty disease? Elderly people. So in our series, the average age was actually 82, but you can get it if you're above 60, and diabetics as well. Generally, especially in the past, it was more in the diabetic population. So all the green numbers in this presentation is our series versus the black, which is the literature. So in our series was only 55%. And what we found actually is that all the patients, all the non-diabetic patients were above 80, apart from one patient. So it seems to be that the diabetics can get it in a younger age, but if you are above 80, you're probably likely to be immune compromised, maybe as much as the diabetics. But also other immune compromised patients, again, we see it in HIV in younger patients who are non-diabetic. So it seems like the more immune compromised you are, the younger you can get it. Male to female, 2-to-1 in our series was almost 90%. We had actually only 3 females out of the 29. So just remember, when you see elderly male above 80, that they don't have to be diabetic, and there is a significant chance that this could be necrotizing otitis externa. And I don't personally know why elderly males, but it more or less sounds like the bad outcome that we are getting from COVID-19 as well, that tends to affect the male. I'm not sure if it is the dodgy Y chromosome, and it is rare in children, unless of course they are immunocompromised. So what happens with this necrotizing otitis externa? So it basically starts in the ear canal, and then it goes into the bone by passing through weak areas in the canal, for example, fissures of Santorini, which is the natural defects of the cartilage of the ear canal anteriorly and inferiorly, goes into the tympanomastoid suture along venous canals and fascial planes as well. Affects cartilages, connective tissue, bone, and nerves. And then it was found that it affects more the compact bone, causing destruction. So it more affects the tympanic ring and the tympanic bone rather than the cancellous bone of the mastoid bone. It can spread along the base of the skull, as we mentioned, and the first nerve and the most common nerve to be affected is the facial nerve, and it affects the facial nerve at the stylomastoid foramen. Then, if it spreads even more medial, it goes into the jugular foramen, affecting the lower cranial nerves, causing bulbar palsy. That you have to consider that that's very serious in an 80-year-old or above 80-year-old, where they get a little bit of aspiration due to vocal cord paralysis, pneumonia, and off you go. If it passes or spreads more medial, it can affect the petrous apex, where it causes abducent paralysis, trigeminal nerve paralysis as well, and the worst prognosis if it goes into intracranially and cause complications. The otic capsule and the middle ear structures tend to hold on a little bit, and it is affected late in the disease. And why does it affect diabetics? There are lots of theories about the diabetics, but we know that with diabetes, you get endarteritis and microangiopathy. This causes ischemia, and also affects with the presence of a local trauma like irrigation, ear syringing. It gives a port for the infection to go in, possibly ischemia, less immune response. Diabetics they've got defects in the immune system in the form of chemotaxis or phagocytosis of the polymorphs or the macrophages, but also the pH of the cerumen and diabetics was found to be neutral, so it loses the acidic, normal acidic pH of the cerumen. And the main organism, as we'll find out in a second, is the Pseudomonas, which actually likes the alkaline environment, and that's why turning the pH of the ear canal into a low pH of acidic nature helps against the Pseudomonas in general. As I just mentioned, the Pseudomonas is the main player here. It's gram-negative Bacillus obligate aerobe. And the way it works, or the reason for the severe virulence, is that it invades local vasculature, causing coagulative necrosis. It produces lytic enzymes like collagenases. It also produces, in some strains, produces endotoxins, causing necrosis due to vasculitis, neurotoxins, causing the cranial nerve paralysis. There is also other microorganisms like the Staphylococcus strains, but the Pseudomonas is by far the most common. You always have to consider the fungal etiology, especially in immunocompromised patients like HIV. And I always advise that if we don't see that the patient is heading in the right direction, i.e. his patient is not improving, we have to consider either that this could be a malignancy or there could be a fungal etiology. So we've seen the patient and how the patient would present. Actually, there is an average delay of about 70 days, it was found, before the necrotizing otitis externa is diagnosed. But I think now this is going to get less because people are more and more aware of it. And you see this in the patients a lot. They come to see you while they are a bit annoyed because they have been seen by the GPs for a long time and by maybe other ENT doctors, and they have not diagnosed the patient, especially if the patient actually develops some cranial nerve paralysis. And I mean, it's difficult to resist the temptation that you are the best one that diagnosed it, but actually it is part and parcel. And I always try to, calm the patients down, that's actually one of the reasons why we are diagnosing it, that other people have failed, or this patient have failed to recover or to get better despite several attempts. Of course, quite a lot of these patients have history of, as we mentioned, recent ear syringing or oral irrigation. And the symptoms that they come with by far are otalgia, and it's the most common, as you can see. But the otalgia here is really characteristic. It's severe and it does not settle. Patients always describe throbbing feeling. And of course, with any inflammation, you can get a throbbing sensation, but actually sometimes this throbbing sensation persists even when the pain disappears. And I think it's mainly also in the far advanced cases where there is exposure of the intracranial content, so there may be transmitted pulsations from the brain. And of course, the otology here is nocturnal, so it's mainly at night. The second most common is discharge, otorrhea, but so far it is earache, discharge, not much different from normal otitis externa. These patients can also describe headaches, TMJ pain, and in some elderly patients, it actually reduces oral intake because they can't chew their food. Every time they chew, they feel the pain. So basically, the patient comes in with pain on the side of half of their heads. Also hearing loss, and the hearing loss here could be due to mainly conductive, but could be due to obstruction of the ear canal by the inflammatory process itself, or could be also middle ear and mastoid effusion because the infection spread outside in the subtemporal region and basically blocked the eustachian tube. And this middle ear effusion, if it happens, it tends to lurk for quite a long time after the resolution of the infection. If you look into the ears of these patients, you'll find, as expected, the ear external auditory canal swollen, tender. You could actually see also swelling in the preauricular area and tenderness. You'll find purulent discharge, but the very kind of or that raises high suspicion is the granulation tissue at the osseo-cartilaginous junction of the floor of the ear canal. It was found that it is about 75% or 72% of patients would have it, and it may not be present with HIV patients. Sometimes patients actually present a bit later with, as we mentioned, cranial nerve paralysis. So facial nerve is the most common, and we found that a quarter of our patients presented with facial nerve paralysis. Other cranial nerves could be up to, as you can see in our series, 37%. And these are late signs and poor prognosis, as we mentioned, due to the patient's age and comorbidities as well. So we saw this patient who came in, elderly male with severe earache. We found some inflammation of the ear canal, granulation tissue at the floor. So what are you going to do? In terms of the investigations, you can do some blood tests and the ESR is actually more sensitive, or tends to be more sensitive as inflammatory marker compared to the CRP. You certainly would look at culture and sensitivity, and we want as more representing culture as possible. So from the otorrhea, of course, but if you go for a tissue biopsy, do not forget to send it for microbiology. As we can see here, the biopsy is very important to rule out malignancy, because one of the major symptoms of malignancy is also the severe pain in the head and the presence of granulation tissue, which sometimes can be very large, that it's basically looks as if it is an oral polyp. And as you can see here, the main organism is, as we mentioned, the Pseudomonas, and the literature quotes 76%. Our series showed 47%, and it appears to be that there is a trend towards negative culture, as you can imagine, because patients have been treated by several topical and maybe even systemic antibiotics. Okay, before we go into radiology, any questions at this stage? Okay, so I assume that's...
I think we're okay, actually. Thanks, Ahmed.
Okay, so the radiology, that's the mainstay for actually the diagnosis. And if we look at the CT scan, for example, the signs of the CT scan could be minimal, actually, in the early stages where there is bone erosion, bone destruction. It doesn't need frank bone destruction like we see sometimes in malignancy. But you can see, like here, where it's spread into the clivus, you can see the loss of just the cortical bone. You can see the cortex all around the clivus here, apart from this side. There is also potentially obliteration of the fat planes if this infection spread outside the temporal bone. But the main thing about the CT that early findings could be just limited to soft tissue inflammation. So it needs actually demineralization, takes demineralization time to occur to get a positive scan or results on the CT. So you have to be very careful when you get a negative CT, because there is a potential for false negative. And if we are going to only do a CT scan, adding contrast makes it more sensitive because it evaluates the extra temporal extension to the soft tissue. But by far, we have to say that the CT is the most available, most effective, and cost-effective as well, and the quickest. So it's really important in management. And again, the difficulty with the CT is that the remineralization of the affected bone, so these bone erosions may never resolve on the scan, or takes a long time, or could be over a year. So again, the CT is not appropriate actually to monitor the response to the treatment. And again, you cannot rely only on the CT to distinguish between NOE and malignancy. The second more common one is the MRI scan. As you can see here, the MRI scan, it identifies, of course, soft tissue involvement. As you can see that there is contrast enhancement here. Sometimes the radiologist could tell you that this is a diffuse inflammation. I can't see a mass to suspect malignancy. But it also shows dural enhancement, intracranial complications, and you can also detect it on a loss of the bone marrow signal by the inflammation. Again, changes in the MRI scan may not resolve with disease resolution, and it can lurk for quite a long time after the infection had resolved. So it's not really ideal for to follow the course of the antibiotic treatment, which takes us to the radionuclide scanning, technetium scanning. As you can see here, it's very useful in diagnosis early. So the cases that are missed by the CT can actually be picked up by the technetium scan. It's very sensitive, but it's also still positive in malignancy. So it's low specificity. And again, the bone changes on the technetium remains positive for years. So it's not suitable really for follow-up. The gallium scan, it basically binds to the leukocytes. So when the leukocytes leaves the tissue, when the infection resolves, it goes back to normal. But the gallium scan is not really common to be done here in the UK. In October or November last year, we had a collaborative meeting that was led by MS Stapleton from Manchester. And there was probably maybe over 10 or more centers from the UK. There was only one center using the gallium scan, and it was in Bristol. And when I discussed, I also tried to push it with our radiologist, a nuclear radiologist, and the response that I got is that this is an old investigation, expensive, and takes time. So is there a role for FDG-PET? We'll find out in a second. So we've seen a patient, diagnosed the patient with through CT or MRI scan. How are we going to treat these patients? Oral toilet is very important, and you need to clean the ear out. Tight glycemic control if the patient is diabetic. It is very important, and some studies actually gives it a weight as much as the systemic antibiotics. Although it is important, but it is difficult because we know with the infection, diabetes could be difficult to control. Surgery, it's been largely abandoned, I have to say, because in the past it used to be done more often, and our experience actually shows that patients who had, for example, mastodectomy or facial nerve exploration, if they go in with partial facial, they come out with a complete facial paralysis. And I think this is most likely due to you're basically opening planes for fascial planes for the infection to spread. So at the moment, most centers would limit the surgery to biopsy from granulation tissue or removal of bony sequestra. Hyperbaric oxygen, there has been suggestion that it may be beneficial, but the problem with the hyperbaric oxygen is you have to give it to the patient several hours daily for weeks. There are risks of oxygen toxicity, barotrauma. It is expensive, not widely available. And there was also a Cochrane review in 2013 that could not prove an evidence to support the usage of the hyperbaric oxygen. So if you go to the main player here, the systemic antibiotics, that's the mainstay of the treatment. It needs to be long-term, culture-directed, at least 6 to 8 weeks, maybe even longer. And it needs to be anti-pseudomonal. The more common is the third-generation cephalosporins like ceftazidime, the second-generation quinolones, the ciprofloxacin, imipenems, beta-lactams, tazocins. And most times we start with IV antibiotic, then shift to oral, and most times as well, we use combination antibiotic rather than monotherapy. If we look at the ciprofloxacin mainly, so why the it's the main working antibiotic. It has got strong bone penetration, it's effective against Pseudomonas, and it's got high bioavailability after oral administration. But on the other hand, there is evolving resistance to ciprofloxacin. Some studies quoting 30% actually, some of Pseudomonas strains, but also it prolongs QT intervals in such elderly patients. It can affect the kidney functions. It may cause tendon damage or rupture of the Achilles tendon, photosensitivity. And it was found that actually lower doses like the 500 milligrams promote resistance. So it is advised to use the higher dose of 750 milligrams. So if we come to the most difficult yet the most important question, when to stop treatment. So we diagnose the patient and we have started the treatment. When do we stop the antibiotic? If you undertreat, you are risking morbidity and potentially mortality. So if you stop the antibiotic early, we found that the patients who had relapse or recurrence, 20% of them actually died. Especially again, so these elderly population group, they can tolerate a hit once, but not twice. If you overtreat, you're risking antibiotic resistance and also risking the side effects from the ciprofloxacin. So it's really a difficult thin line here. So again, if we go back to the French group, amongst the 48 publications, they looked at 30 of them that mentioned the treatment in details. They found that 91% used ciprofloxacin as a higher dose, 750 most commonly. And some of the studies actually used it for 24 weeks. It's almost 6 months of antibiotic treatment. And since 1995, there was only 2 series who used monotherapy, and the rest used a combination of antibiotics. And again, it is understandable due to the emergence of the resistant strains. When they looked at the follow-up criteria, 24 out of these 48 studies mentioned the follow-up criteria, and 11 of them relied on the gallium SPECT scan. Most authors used multiple criteria. Some authors used only ESR, and some others used the clinical relief. And I have to say that the relief of pain and clinical symptoms, to my mind, are very important, but also it's more sensitive towards the recurrence. So if I see a patient whose ear looks absolutely fine, but then they start to complain of headaches, again, that's when it starts to raise the alarm that the infection may have recurred. Then there was another systematic review that proved that they actually cannot rely on the CRP or the ESR to guide the treatment. And in 2014, May Clinic produced a kind of systematic review of the literature as well. And they concluded that, again, MRI and CT can persist long after therapy, as we mentioned. And they raised at the time, 2014, that the FDG-PET may be a viable imaging option in future. Then a group from Israel, actually in 2018, they made a specific study for the FDG-PET, and they found that although they had 12 patients only, which is a relatively small number, but actually 8 of these patients could stop treatment after 6 weeks, relying on the PET. And they concluded that the PET-CT could be a reliable, or is a reliable imaging modality for the diagnosis and decision-making regarding treatment cessation. Another group, but they were looking at osteomyelitis in general and the long bones. And again, they came to the same conclusion that the PET scan is better than the MRI scan in terminating the treatment with antibiotics with osteomyelitis. If you come quickly to the outcome of this disease, as we mentioned, mortality, the average along these 48 studies was 4.2%. Ours was slightly higher. And there's also a relapse of about 99% or 10%. What I couldn't find easily in the different studies is actually what happens to these nerves that were paralyzed. And we found that, for example, the facial nerves, we had 10 patients out of our 28, 4 of them remained the same, but actually 6 of them showed improvement. But what we found is that if the patient comes in with complete facial paralysis, unlike House-Breckman grade 6, unlikely that, or they have not, none of them reached back completely to normal. They improved, but not back to normal. But the ones that came with grade 3, grade 2, they could achieve basically normal facial function. In terms of the other lower cranial nerves, actually it was a little bit better, and to the surprise that we had 8 patients and 4 of them recovered the lower cranial nerve function. And abducent paralysis was actually 50-50. So it is a disease that is quite, can cause problems and may be slightly tricky to treat. And we are in the process of developing protocol incorporating the PET scan, but actually the ENT UK has produced in March, I think people have got some time on their hand now, about managing of the necrotizing otitis externa. And I think it's quite a good protocol. There are a couple of comments because they suggested surgery sometimes, but also MRI scan 6 weeks after the antibiotic stoppage. And I think the MRI scan, it's not clear on the guideline, but the MRI scan after 6 weeks of antibiotics is probably to show that there is no further progression, rather than to say that's clear and you can stop the antibiotic. That's it. Okay, any questions?
That's fantastic, Ahmed. That really covered everything very nicely and dealt with quite a lot of issues that certainly I am not 100% clear about, particularly the recovery of facial function and other cranial nerve defects. We've had a couple of questions. The first was, is there a role for surgery? What are your thoughts on that?
I mean, as far as my personal experience, we've never had to resort to major surgical debridement, like or even mastectomies. The patients, as I mentioned in the presentation, that we got from other centers who had cortical mastectomy, because sometimes these patients can be tricky, where you see a pacified mastoid and facial palsy, and patients or people starts to think, oh, could this be complicated otitis media? They explore the mastoid and possibly decompress the facial nerve, and the patient comes out with complete facial while they initially had partial facial. So, and so far, we've not been in a situation where we actually needed to do major surgery. And I have to say also, seeing the more advanced, complicated cases, you can't really take half or quarter of the patient's head out, and you won't be able to ensure that you have cleared everything, because most of these cases would have spread to the central skull base, maybe even nasopharyngeal, up to nasopharyngeal swellings as well. So my personal experience that we didn't really need to resort to surgery with these patients, or major surgery with these patients.
And for example, if somebody was to develop an abscess, and you do sometimes find abscesses in the cavity.
Yes, yeah. So like that. Yeah, I mean, we had very occasionally that we even needed to incise the some abscess pus collection in nasopharynx, and this will help also with deep biopsies for microbiology as well. But it's certainly, yeah, if there is a collection, of course, that we'll probably have to drain it.
Okay, and just one final question, because it's gone half 10, but you mentioned that in some patients, particularly HIV and that kind of thing, fungal disease is an issue. How do you judge whether to treat with antifungal agents as well as antibiotics?
Yes, I mean, to be fair, if there is no suspicion, we start with the antibiotics first. Unless, of course, the patient is immunocompromised, then they probably have to cover the fungal as well. But it's only, I mean, we had only 2 cases really in our series, but it's only when you do not get the improvement you would expect after maybe a week, a maximum 2 weeks of being on antibiotics, and the patient's pain still there and is still not resolving, then you start to think, you know, could this be fungal? And of course, if malignancy has been ruled out, then you start with a microbiologist to see if they can be put on amphotericin B, or sometimes put itraconazole with the treatment.
Great. Okay. Well, thank you. That was great. So.